Okay, continuing with the neuroophthalmology topic, we will study now the pathologies of the optic nerve. First, we know that this is a optic disc from which the vessels arise. These are the branches of the central retinal artery, the four arteries, and the corresponding veins. Okay, so what are the different pathologies of the optic disc? The disc can be swollen, inflamed. Okay, what are the causes of the swollen optic disc? What is a swollen optic disc? For example, this disc appears swollen. The first feature of the swollen optic disc is that the disc margins up, will appear edematous, that is, they will not be distinct anymore. What are the various causes or etiology of a swollen optic disc? It can be due to papilloedema, due to the raised intracranial pressure. It can be any space occupying lesion of the optic nerve head. For example, optic disc drusen due to optic nerve glioma, due to sarcoidosis, due to leukemias. It can be due to the papillitis, that is, it is just a very minor inflammation of the optic disc. It can be due to the accelerated or the malignant hypertension. It can be due to the ischemic optic neuropathy in the starting stage. It can be due to CRVO. It can be due to pseudopapilloedema, which appears papilloedematous. The disc which appears papilloedematous, but it is not. It can be due to myelinated nerve fibers around the optic nerve head, and also due to the peripapillary atrophy, as seen in the cases of high myopes. This is the example of the swollen optic disc. This actually is the optic disc drusen. Optic disc drusen. This disc also appears edematous, but it is actually the myelinated nerve fibers around the optic nerve head. This is the actual disc, but the disc margins don't appear distinct, and this is seen due to the peripapillary atrophy of the retinal fibers in myopia. Papilloedema due to the raised intracranial pressure. We know that optic nerve sheath of the dura mater and retinoid matter is continuous with the subarachnoid space of our brain. Okay, as the CSF pressure in the brain increases, either due to the some space occupying lesion, or it increases due to the malignant hypertension and the resulting intracranial pressure increase, the pressure is transmitted to the optic nerve, to the eye. The sheath acts as a tourniquet and leads to the build-up of the material at the level of the lamina cribrosa. So the exoplasmic spaces happen at the lamina cribrosa because of the swelling of this nerve head, and you have to also see that papilloedema may also be absent in the cases of prior optic atrophy, and most likely secondary to the decrease in the number of physiologically active nerve fibers. So it is not that every time intracranial pressure is increased, papilloedema will be there. Sometimes when there is optic atrophy, there will be no papilloedema. This is the figure. This is a picture showing the papilloedema of the disc. What are the causes of the increased intracranial pressure? The most common one is the idiopathic intracranial hypertension. The other causes can be intracranial tumors, craniosynostosis, any cerebral edema either due to trauma or infection, encephalitis, obstruction of the ventricular system at the foramen of Mejenge or Luschka, decreased CSF resorption from the arachnoid villi, increased CSF production, medications such as tetracycline, nalidixic acid, and steroids. Medications is very important to take the history of the medications. History in the patient having raised intracranial pressure, we should ask for associated visual loss, which is very rare. Any transient visual obscurations, blurred vision, constriction of the visual field, decreased color perception, diplopia because of the sixth nerve palsy, which is also known as the false localizing sign, any headache worse on waking up and made worse by coughing, nausea, retching, vomiting, pulsatile tinnitus, any history of trauma, any medications. This all we have to elucidate in the cases of increased intracranial pressure. What are the signs of papilledema? Signs of papilledema on the fundus examination are the swollen optic disc with the blurry margins, as we already discussed. There are dilated and prominent superficial capillaries. No spontaneous venous pulsation of the central retinal vein is seen. Okay. Hemorrhages over and adjacent to the disc are seen. Patens lines, which are the edematous lines concentric to the optic disc, are seen. Patens lines, which are the concentric lines, edematous lines of the in the retina concentric to the disc, are seen. The color vision is normal in cases of papilledema. There is no RAPD in the cases of papilledema. Important points. In the visual field testing, the blind spot is enlarged and there is a constricted field in chronic cases of papilledema. There are abnormal neurological deficits which can be seen. See, this is a photograph of the patent lines which can be seen around the disc. What are the various investigations of the raised intracranial pressure? CT scan and MRI of the brain with contrast is to be done. Why it is to be done? To identify any space occupying lesions. MRI venography is important. Why it's important? To detect any sinus thrombosis. D-scan ultrasonography is done to rule out any disc drusen. Fluorescein angiography to why is fluorescein angiography done? To see the disc edema due to the leakage at the disc. How much disc is leaky? Okay, and the lumbar puncture to see the what is the raised, how much the intracranial pressure is. This is a papilledema. The disc margins are blurred, FFA of the papilledema, and this is seen in the leakage from the disc. And this is the FFA without papilledema. The disc, though hyperfluorescent, is not leaky in the leak stages. What is the treatment of the raised intracranial pressure? We have to treat the underlying disorder. Papilledema will resolve within a few weeks once the intracranial pressure has been normalized. Optic atrophy usually remains. Neurosurgery is required for any space occupying lesion and the hydrocephalus. And for the hydrocephalus, what we do is a ventroperitoneal shunts. Next disease we will study the idiopathic intracranial hypertension, which is responsible for the papilledema in most of the cases. In this, there is elevated intracranial pressure and the presence of the disc swelling with no evidence of the intracranial abnormality and no dilatation of the ventricles on the scan. Okay, there is no evidence of any intracranial abnormality. There is no dilatation of the ventricles of the brain on the scan. Overweight women in the second or the third decades are the most common presentation. Exposure to the drugs such as contraceptive pills and tetracyclines are also high risk factors. Okay. Headache, obscurations of vision, sixth nerve palsy, that is the lateral rectus palsy, the eyes in the adducted position, and no other neurological problems point towards idiopathic intracranial hypertension, where we don't know the reason of the intracranial hypertension. It is the idiopathic intracranial hypertension. In this IIH, there is a progressive contraction of the visual field if the nerve remains swollen for weeks. Okay, if the papilledema continues to remain, there is a contraction of the visual field and we have a primary gaze vision only. What is the treatment? Treatment of IIH is by reducing the intracranial pressure. And how do we reduce it? By the medications like oral acetazolamide, ventroperitoneal shunting, and optic nerve decompression. Next entity we will study about the optic nerve disease is the optic neuritis. It is an inflammation or demyelination when the optic nerve demyelinates. What is papillitis? when only the optic nerve head is affected due to the demyelination or the inflammation. What is retrobulbar neuritis? Nerve is affected more posteriorly with no disc swelling on fundus examination. Many of the cases of optic neuritis are associated with the multiple sclerosis in the age group of 20 to 45, more in females and Caucasians. What are the causes of the optic neuritis? 50% of the patients of multiple sclerosis present with optic neuritis. Other causes can be infections such as syphilis, Lyme's disease, herpes zoster, any autoimmune diseases such as the lupus, inflammatory bowel disorder, drugs such as chloramphenicol and ethambutol, any vasculitis, any diabetes. Okay. What history do we take in the patient of optic neuritis? Usually the optic neuritis affects one eye initially and then both the eyes can be involved. There is acute loss of vision that progresses over a few days and then slowly improves. Okay, and some have a vision loss that is permanent. It varies from a small area of blurring to complete blindness. The distorted vision, and there is a reduced color vision. In papilledema, the vision was not affected and the color vision was normal. There is pain on eye movement in the cases of retrobulbar neuritis because of the pain receptors on the medial rectus muscle. The preceding history of viral illness is important in such cases as it helps us to have a have so that we know that it's multiple sclerosis, so viral illness helps. And 40 to 70% develop other neurological symptoms to suggest multiple sclerosis. Okay, as such, multiple in the Donald's criteria of multiple sclerosis, optic neuritis is not a finding, but still 40 to 70% have to develop other neurological conditions so that we think about multiple sclerosis. What is examination? The visual acuity is examined, it is reduced, and the color vision is also reduced. There is relative afferent pupillary defect due to reduced optic nerve conduction. Central scotoma is seen on the field testing because of the involvement of the fiber. There is normal disc in retrobulbar neuritis and a swollen disc in papillitis. This is the figure showing the papillitis. The disc margins are blurred and the disc margins are totally blurred and the disc is swollen. MRI scan helps to identify additional silent plaques of demyelination in the central nervous system, that is the brain or the spine. Diagnosis of the multiple sclerosis is essentially clinical. McDonald's criteria. Treatment with steroid may speed up the visual recovery in such cases of optic neuritis. The immunosuppressive therapy is also given like methotrexate. Another important point is that vision slowly recovers over weeks, but not quite as good as before the attack. It returns to normal but not fully normal. It returns subnormally. The repeated episodes of optic neuritis may lead to optic atrophy and lead to the decline in vision, and the vision may not recover in atypical cases. Okay, vision may not recover in atypical cases. Next, we will study about the ischemic optic neuropathy in the next video.